entitled this Still Filling Potholes. So what I thought, this is going to be a slightly different presentation. I was going to talk about some of the practical problems that we've been through, and it feels sometimes like we're walking through a treacle, working in partnership. So we're also 8 partners, 780,000 population in Dorset, 3 acute hospitals, 3 local authorities, and a mental health community trust. Oh, well, maybe not. Sorry. Okay. I was writing this about Halloween time, and I thought it would be quite interesting, not least because we had a problem with a patient who wouldn't die. So, I'll talk about that. And then something about consent, something about coding, and sorry to anyone who's a cat owner, I've got a cat as well. Other priorities, moving on to LACRA, and then something in the virtual world, which is where Matt Hancock inhabits, I think, and a little bit about our usage and single sign-on. So that's kind of what I was going to try and cover. So the undead was a patient, and these problems only ever get to me when they become big problems, or well after they happen. But this patient got marked as dead in one hospital, and 2 days later, somebody in another hospital cancelled a GP referral. Now, clearly they did that in good faith. They probably did that because they'd actually been told the patient isn't going to turn up because they're dead. But they didn't mark the patient dead on that hospital system. And what it did on DCR, on our shared record, was it brought the patient back to life because that was the latest information, the latest update to the record. So being sceptical, I said, what does the spine say? Because the GP would have updated the spine, and that might be useful, and that they were also dead there. It was interesting because it was in the natural catchment of Hospital A, the one that originally marked them as dead, and it was out of area of Hospital B, so they weren't really looking out for it. They wouldn't be, their normal process wouldn't include that patient because they lived actually pretty much halfway between the two. So, I mean, one of the interesting things, and we haven't got it, and it's one of the, it's one of the challenges. Well, how could Dorset Care Record proactively have helped in the situation? How could it have made life better? Well, clearly, this is the place where we're bringing all this information together. So whether it was the patient, I don't know the detail, whether the patient died at home or died in Hospital A, but wherever it was first notified, actually, if the system could go, hang on a minute, I know about this person in these other 4 places. Why don't we send something to those teams so they actually know? Because serendipity or otherwise, the clerk in Hospital B that cancelled the appointment, that was because someone in the GP practice thought, oh, we'd better tell them, otherwise they'll be carrying on and wasting that space. So some means of automatic notification. This ties back into some of the intelligent use of information, the reporting, and how we get some of that sort of stuff done. There would still need to be manual updates to the records. Unfortunately, we can't automate the whole process because very often there's things like pathology and other things in train. So just killing off the patient completely automatically may not be the right thing to do. Hospital B isn't connected to the National Spine, and we had a bit of debate about whether that would be a good thing, and it would. But just because you're spine connected doesn't mean you're always right up to the minute, because it involves you actually going off and asking a question, a trigger, which is normally a new piece of activity. So for some of this stuff, it still wouldn't be up to date with the event because no new activity was taking place. Our second problem was around consent, return of the paper. Now this was quite an interesting one because our community mental health provider used to have, or I hope they've got rid of it now, a paper consent form. And they realised after we'd gone some way down the path that actually there are 160,000 of these paper consent forms, and they'd scanned them all and stuck them on the record. But they couldn't tell you which of them had, you can share with whoever you like, or Mrs. Jones works in the outpatient department, she's my neighbour, I don't want her to see it, or don't share with this service over here. So their response to that was, we need to write to all 160,000 patients to tell them that they might or might not have given consent before, and would it be all right for us to use the record? Then the local authorities all piped up and said, well, actually, we've got a shared consent record. That's also on paper. It's also not coded in any way, and it's also scanned onto our case management systems. And 2 of them said, well, we like the idea that the others have got, and by the way, will you pay for it? For a letter to go out to all of our clients. And the acute hospitals, and Peter's one of the acute hospitals from Dorset sitting here, were going, we are certainly not going to write out to all our patients. And what happens when a letter arrives from you and they don't get something from us, but they're in touch with us as well? Now, fortunately, the third local authority said, actually, we should be taking a much more proactive risk-based assessment. What's the risk of someone actually having a problem with this? It's probably quite small. But as a result, we went to the Information Commissioner and asked their advice, and they actually came down to see us because they were quite interested to come and talk to us. Not not with a big stick, but to learn together. And they said something which actually I picked up from Camden some while ago, but also from our local LMC had a meeting where they had a legal advisor talking to them saying we really shouldn't be using consent, we should be using the legitimate processing for public purpose. And that's what the ICO said. So I thought, oh, okay, that's what we said. And they also said that our engagement to date had been good, but the problem with that is we've spent a lot of leaflets out there and a lot of communication with people telling them about our consent model. So we now have to send them out a piece of paper, but we've agreed it's not going to be a letter, it's just going to be a leaflet, and we'll try and do that as quickly as we can, really to move over to the legitimate processing for direct patient care approach. That also means we've potentially got to change our consent model within the Dorset Care Record, and how we do that and how we do that minimum fuss was something I was talking with James about over lunch in terms of who knows what the next batch of information governance people might want to say and whether they might want to undo it, so let's not do anything too peremptory. The different way to skin a cat. This was about particularly our local authority colleagues don't actually have an equivalent of the NHS data dictionary. So when you get to looking at things like relationships, they have far more complexity because they're dealing with complicated families quite often, and so they want to know about step siblings and other adults in the room and in the family home and that sort of thing. So the detail that we need to go to for them is far more than we store in the health system. Not only that, but the three local authorities have all chosen three different ways to record the coding for those relationships. So we have to map those all across, and of course they don't have integration technologies in place to be able to do that themselves. So that's been a bit of a challenge. We also had a challenge with ethnic origin. I really wasn't expecting this one, because in health we have two levels of aggregation in terms of how we record ethnic origin. In children's services, they use the education standard, which is a national standard for local authorities for education, and in adults they have another national standard. So it kind of comes back to, you can have as many standards as you like. There was a slide, wasn't there, earlier with many of them. So that's been a bit of a pain, and trying to persuade them all that all work together. I did have one of the local authorities said, what about is it Vogon? And apparently there are 2,000 people in the country who would identify as that, and therefore it is a religion, but I didn't know that. And it's also not got a code. The third one was around minimum data set. So this was around the new minimum data set for emergency care. So emergency departments have to submit an emergency data set. That has two problems. One is it's much bigger than the other one, so it's more clinically rich and more useful. But there is an overlap. So a 1 to 8 is in the new codes with a different description than the old codes. How silly is that, NHS, whoever did it, NHS England? So that's been a problem because one of our hospitals send the new codes. The other hospitals, although they report the new codes, they send the old codes because that's the interface they already had in place. So that was also, these are just some of the things that have been tripping us up that I thought I'd share with you just in case you either haven't hit them yet or you might identify with them. The next thing that's been interesting is other priorities. And I put the acronyms at the top there on purpose just to confuse everybody. But the Dorset Care Record really is trying to do this bit. So we're taking information as others were oops, press the wrong button. As others have identified, across the bottom are operational systems feeding through trusted integration engines of the local authorities. They don't really have anything, so feeding directly into the Rhapsody integration engine and feeding the Orion portal. Gone the wrong way again. But our acute hospitals in particular are trying to deliver the clinical 5. They're very busy trying to sort out electronic prescribing and clinical front ends and order entry and transfers of care and getting rid of paper out of their system. And that's consuming huge amounts of time for exactly the same, particularly integration engineers that we're trying to use for our piece of work. The local authorities in our area are in the middle of reorganisation. There are currently 3 top-level authorities and they are reorganising into 2. But the 6 district authorities, that are under one of them, one of those is being pinched from the rural area into the urban area. So they're in a state of some turmoil in reorganising all of their systems to suit local government disorganisation. They've also very recently been replacing both adults and children's case management systems. They're pretty much at the end of that now, but that's been fairly traumatic for all three authorities because they've all done it at pretty much the same time. And then we have, quite early on, I was saying, well, what about social care providers? Because your local authority is not the ones delivering care, it's the many people doing domiciliary care and in care homes. And they're not really they've never really been part of our picture. Because the local authorities said, well, there's hundreds of them, we can't dictate from the centre what they do, so we won't really involve them in the process. And similarly, sorry, I'm now bottom left, the hospices and the out-of-county hospitals, and we had planned for those, but in the process of discussing things as we went forward, they sort of fallen off the back of the truck for now. But when we go and do consultation with patients, the public, in the north of the county or in the west of the county, they're going, well, what about, we like Yeovil Hospital, or the waiting times are shorter at Exeter, so we go west. And so we're hitting that with them, going, well, it's not much use in this part of the county either then. So that's interesting. And then the last one was the LIMS. So our laboratory, I think this is a national problem, but around the whole country that there is an aggregation of pathology services, and for us part of that is replacing the laboratory information system. So we have a very tight window that we're trying to squeeze into to get the pathology results out before they get completely subsumed in merging with all of the Dorset, Hampshire, Isle of Wight and South Wiltshire laboratories, all becoming one shared service and using a new laboratory management system. So some of that is why we have a lot of busy people all around the system, and why we've got what we call a bow wave in terms of delivering what we're trying to do through the Dorset Care Record. So there's been lots of good reasons for it, and a lot of this is about trying to persuade people that the executives at the top of our shared organisation sit down in a room together, our senior leadership team, and agree, in digital space, the Dorset Care Record is the most important thing we could be doing. And then the executives below that also believe that, but the guys on the ground are trying to struggle with all of those priorities I've outlined on the previous slide, and dividing their time, slicing their time up, and that's caused some grief to us, I have to say. And then there's LACRA. So Muggins offered to get involved in volunteering Wessex to be one of the LACRA areas, and we were probably more surprised than anybody that we were one of the first three they announced. And that's great, and it truly is great, but part of that is about what we do with our colleagues to the east. So Hampshire to our east has the Hampshire Health Record, been in place for a very long time, got a very rich source of information there. They now call it CHI rather than Hampshire Health Record. I think that's just to confuse everybody, but every time they talk about it, they go, previously known as the Hampshire Health Record. And it's covering the same sort of ground. But the interesting bit for me, I suppose, is what we do about the Master Patient Index, and obviously we've got the NextGate system, and they've got something wrapped into what they've got. What we do about pseudonymized, anonymized information, because the whole purpose for me of the LACRA is about working together to work through the intelligent working around the patients and bringing that information back into the front line to enable people to do a better job with Frontline. And we're still very early in this, and we haven't quite decided exactly, I've drawn those boxes in that way because that's kind of what I've been thinking, but we haven't really quite got to an agreed position. And part of that is because the centre, having got 5 places they can bombard with information, we get so many meetings, I should be on teleconference right now, with the centre about how we're going to architect things, which is dividing time even further. And yeah, obviously the integration engine's feeding into that. But then, as I said, the national assets, some of which you've heard about already, and some of which are really helpful, and others of which we think, well, yes, that's delivering your national asset, but is it really what we want to be doing? And so part of our challenge is to try and make sure that we're adding value by using those national systems. So things like the event management and the National Record Locator Service are being piloted, particularly around, interestingly, with the ambulance, with mental health crisis plans. But where do they sit within our piece we're working through? And then there's the Secretary of State, Matt Hancock, who has stood up and supported the use of tech very heavily. And interesting, if you follow him on Twitter, he's getting attacked by various patient groups going, stop talking about all this tech, talk about my disease and solve my disease. So, he's going to come under fire for all sorts of other reasons. Never mind about this new fancy stuff. Let's worry about clinical problems that are happening to me right now. But certainly at the moment, he's pushing quite hard with some really good stuff. But there's one or two things here that worry me slightly. One is the data layer with registers and APIs, because what we have mostly brings information to the centre for good reason around being able to do knowledge support and decision support and intelligent stuff. And the other is the separation of the layers of the stack. And these are really sensible things, and it's really where we need to be in terms of the internet technologies. But it's the how quickly we get there. And we had a debate end of last week with the centre from the various LACRAs saying, actually, we need to persist some of this information. It can't just all be around an active API, go and get it on a live model, partly because we will knacker all the other systems. If you're going out calling information from other people's systems, then you're going to potentially hit their operational capabilities as well. So there needs to be a judicious mix. We need to be able to pull information that you will rarely use or that is large and you need it when you need it. But hold information that is going to be important for decision support and for active use. But support at that level is really useful. I had this morning. It's why I had to plug in my own machine. We've seen the study. Well, we went live back in March, and our rise has been modest, I have to say. This is the yellow is individuals, and the blue is logging on. So in November, we are starting to see some activity. And interestingly, it's the local authorities that are the most active users of the system. Now that's particularly because the information we put on there first was the MIG. And I mentioned earlier on the summary care record. We were one of the first 6 areas of the country to do the summary care record. But because we'd gone that path and because we got permission from all our practices bar one to go on to the summary care record a long while ago, we were able to go out and say, well, this is what we want to do with the MIG. And we got all but 2 of them are live with the MIG from day one. So we were able to say pretty much the whole population was covered. And we've got 84 practices, so that was quite a significant endeavour to do. I also got another piece of information yesterday, which was the number of times that the MIG got access in October, and that's the first time I've seen that. That was quite a useful piece of information, but it was also quite worrying because 25% of them failed. So it went and called for a record, and a quarter of them failed. Now, I think part of that we know is because a number of practices, and somebody else mentioned it, I think Andrew Brown has mentioned it earlier, that a number of practices are merging, and as they merge, they're picking one of their practice codes rather than the other one, and the MIG needs the NHS number and the practice code. So if you go with an out-of-date practice code, it just says, no, I don't know that patient, and sends it back as an error. So we're trying to fix that through, again, it was something Andrew mentioned, the PDS over mesh, so accessing the information from the GP practice on an overnight upload data basis, so that at least the Dorset Care Record has the most current information. It's another area where, if that information changes, it would be great to be able to push it back to particularly the hospital without spine access, but actually to any of them to be able to know that they're up to date. I've moved beyond Halloween to some good stuff now. So Orion have been working with our key suppliers and on single sign-on, and so we've seen some proof of concept on these. We're not yet live with them. We're quite close to hopefully doing that, and really keen to make that happen. The one that probably stands out, well, Care Director, we've still got a little bit of work to do with, but TPP, we didn't quite get a meeting of minds on. So what we're trying to do with Orion's help is to look to access, to use the credentials off the smart card rather than directly with TPP. You can launch from TPP into another system, but it's a launch and forget. I struggled to persuade them that it was not very safe to have the username, password, and NHS number in the URL. So they have now changed that so it's encrypted. But it took quite a lot of persuading just to get them to make that little change. And we're also keen to get in things like launching the PACS viewers and getting value there. I thought it'd be useful just to end on this, and this is really interesting because this was pretty much the very first day we went live. It snowed. And we don't get snow in the south of England. In our area, it snows once every 10 years, and everything locks up because we don't really have any gritters or any means to deal with it. So this was someone from the Borough of Poole from the social care help desk, and he was able to look at a record for a lady they were concerned about because of the bad weather on day one, and he immediately found this was making a significant difference to the care that they could give to their clients. And so that was felt to be really useful.